You're listening to the first episode of You're a Doctor, Right?
You're listening for the first episode of Your Doctor, Right? You're listening to Your Doctor, Right?
People ask me more questions because she's a doctor.
I love you. I love my mommy and daddy.
So You're a Doctor Right podcast.
Don't touch the mic.
So You're a Doctor Right podcast. Take one.
Hi, everyone, and welcome to the first episode of You're a Doctor, Right? My name is Dr. Sonya Bhole, and I'm a board-certified radiologist. I want to introduce our first guest today, who is Dr. Silas Hoxie, a board-certified anesthesiologist who happens to be my husband. Welcome, Silas.
Thank you for having me, babe.
So today we're going to answer all of your most common questions about anesthesia. So common questions from, am I going to wake up after I get anesthesia, to what exactly are the risks of anesthesia if I want to have a tummy tuck? Full disclosure, I just had one. To, what should I be worried about? What questions should I be asking my anesthesiologist at the time of childbirth and an epidural? What does that actually mean? What are the risks to me and my baby? So today we're going to be answering some of these really common questions with Silas. So we're so excited to have him. Before we get started, I want to kind of give you a little bit about my background. I'm a breast-trained radiologist. That means I read anything that's related to the breast, mammograms, MRIs, ultrasounds, and do breast-related procedures such as biopsies or placing tiny little marking clips into the breast for the surgeons to take areas out. Did you even know what I did, Silas?
I know that you're a super mom and a pretty good wife, too.
Oh, thanks. Well, that's my background. Silas's background is he's an anesthesiologist that specializes in cardiac surgery. So anesthesia for cardiac surgery. So he's very well read and he's a perfect expert to have us on today.
Thank you for having me. I'm honored to be here for your first podcast.
Thanks. Before we get started on our episode today, I want to remind all listeners that the content of this podcast is for informational purposes only and does not constitute formal medical advice. Do not delay in seeking professional medical care because of something that you have heard in this podcast. If you have any questions regarding your own health, please talk personally to a doctor or other healthcare professionals. Relying solely on the information provided in this podcast should be done so at your own risk. Now that we're done with the paperwork, let's get started on this episode today. So this happens to be our living room. So welcome everyone to our home. We just happen to not have all of our kids running through for the next 10 minutes. So we got to get this done really quickly, okay?
I know, because I want to have a cocktail before the kids start torturing us. So that's what we should be doing when the kids aren't here.
Yeah, I'm not sure if that's going to happen, but we can at least get through this podcast. So I wanted to talk about really quickly about how we met. We met our intern year in the North Shore of Chicago. I think your quote was, you thought I was cute, but I wore my scrubs really high. Is that
You were
right?
really, really cute. Just finished medical school. You were very, very excited to be a new physician, new doctor. And I think your excitement showed in just the height that you had those scrubs. You just hiked them up super high, just excited to be there. But you still were beautiful nonetheless and very charming.
Oh, thanks. Well, that was before there were really cute scrubs to wear. So scrubs have come a really far way. And I knew he liked me because it was after a 24-hour shift. I was walking into the ICU and I saw him catch my eye and he turned and immediately grabbed hand sanitizer and put it through his hair. So his hair looked good for round. So I knew I had him then. So
Gotta look good.
the rest is history. So let's dive in. So the reason that we started this podcast is because we really quickly realized that people like to have doctor friends. So we are constantly getting questions of, what do you think about this? And what can you look at my child's rash? And what do I do about this cold? And we found out pretty quickly that at cocktail parties, people would be coming up to us and say, you're a doctor, right? What do you think about X? And most of the time we have no idea about X. I mean, I guess we have an inkling. We did go to medical school, right?
Long time ago.
But a lot of these common questions we really don't have the answers to, but we usually have the resources to direct our friends to where to get these answers. So in this podcast, this series, the first season, we really want to be answering some of these common questions that I've been getting at cocktail parties or at dinner parties, because those people are asking all the same questions. So it's nice to have one place that everyone can go for the answers. So let's dive in.
Let's do it.
So tell us, what is the most common question you get about anesthesia at a cocktail party?
At a cocktail party, I mean, I've been to a few in my day. Don't go too often, but I will say that people definitely want to hear funny stories of people, what people say when they're under anesthesia, funny procedures that people will have, and what happens in the OR stays in the OR. So keep it professional. We don't repeat too much. There are some funny stories out there for sure. But I will say that the most common thing that people are really terrified about that they'll ask me about is am I going to go to sleep and I'm not going to wake up? They perceive this huge risk of going under anesthesia and dying or having some sort of catastrophic event happen to them during surgery. So yeah, I would say that's the most common one that I get is doc, I'm afraid I'm going to go to sleep and I'm not going to wake up.
Well, I actually had those same fears. So what is the percentage of time, or what is the risk to someone going under anesthesia? Is it high? Is it really low? Where does it lie?
So I will say, so the risk of, certainly it varies by the surgery. You can have very high risk surgeries where you're very blunt with patients. This is very high risk. Patients that have certain medical problems going into the surgeries can make them higher risk. Somebody has a bad heart, bad lungs, that sort of thing. But for, the most typical, healthy, maybe a couple minor medical issues going on, having a fairly routine procedure, the risk of having a catastrophic event like dying while you're under anesthesia, having some severe stroke while you're under anesthesia is very, very rare, like on the order of like 1 in a million. So I typically tell people before surgery when they say these kinds of things, and they say, I'm just afraid I'm going to go to sleep and not wake up. I say that probably you underwent more risk, at least as far as just a complication related to the anesthesia itself. You probably underwent more of a risk of a complication like that when you were driving into the hospital. And they usually turn to the, partner or whoever's with the patient, say, depending on who drove.
Yeah. Well, it sounds like you've heard that before then. So.
I've heard that one before. So it's very, very safe these days. Again, certain patients, certain surgeries are high risk, but for the more common procedures, bread and butter procedures that we do, the risk of a very serious complication related to the anesthesia itself, the catastrophic complication is very, very rare and unlikely.
Okay, well, that's really reassuring. And that's why it was so nice to have an anesthesiologist at home before I had my recent surgery. So I felt a lot better about going under. But even as a doctor, even being married to an anesthesiologist, I think these risks or these worries that people have are just really common and really normal. So It's nice to know that those risks are really low.
Excuse me. No, I think a lot of it is just like people getting on an airplane, and flying. It's kind of a loss of control. You're kind of giving control over your body functions, things like breathing, things like controlling your blood pressure over to somebody else, somebody who's a professional, obviously, but there is that loss of control, which is very terrifying to some people. And particularly some people are it's probably similar to same people that are afraid to get on an airplane, very, very afraid to go under anesthesia for those reasons.
I don't know what that means. I'm totally fine with not having control of every situation. So, okay. So that is really, really reassuring. And, I think one of the other questions I've heard recently a lot, but as our friends, as we get into our 40s and people are having more elective or surgeries that they have to have, people have a really hard time with not eating and drinking for so many hours before the surgery. I hate it too. I think it's miserable to not be able to drink water.
Yeah.
What are those rules? Why do they exist? How many hours can you really not drink before surgery? Give us a skinny on that.
Sure. So no, it is tough. And I feel for folks that, especially if your procedure is like late in the day and you haven't been able to eat anything all day, or maybe you snuck in a midnight snack, nothing since then, it is tough. And when I'm asking somebody before I take them back for a procedure, when was the last time you had anything to eat or drink? And the later in the day it is, I'm more likely to say something like, I'm really sorry to bring up a sore subject, because I know that it is tough. And oftentimes there's like family members in the room, like eating, lunch or McDonald's or something. And I'm like, come on, really? Like you're torturing this poor patient. But it is for a good reason. So the American Society of Anesthesiologists, who's more or less the kind of one of the main governing bodies that dictates practice guidelines for anesthesiologists, are very clear on the guidelines for NPO guidelines, we call them, which is basically the guidelines which determine how long you can go between your last meal or drink and your procedure. And those are very, very clear guidelines, because one of the risks of anesthesia is while you're under the anesthesia, your normal reflexes that prevent you from food or gastric contents from getting into your trachea, into your windpipe, those are knocked out along with other bodily functions. So it is a real risk for any food that's left in your stomach or liquid to get into your lungs and cause a real problem. So those guidelines exist for a reason, and they're very, very clear and specific.
Okay. All right. Well, that makes sense. Because it is, so it's not just to torture someone. There really is a
Not trying
medical
to torture you.
reason or why we can't.
Right. So the guidelines are if you have a heavy meal, we typically have to wait 8 hours until
Okay.
we can safely perform anesthesia and a surgery on you. For a lighter meal, and what that really means is something with no fat at all, like just crackers, we can wait 6 hours. For clear liquids, those tend to pass through your stomach very quickly. So that's more like 2 hours.
Okay.
And the reason that people say, oh, my surgery is not till 3 o'clock in the afternoon, why was I told not to have anything since midnight, is the OR schedule. It's always a bit chaotic, hectic. Cases will cancel, emergency cases will get added on. So you'd hate for, say the case before yours or the surgery before yours cancels, and there's an opportunity for you to have your surgery earlier in the day, for you not to be able to, get in and out at an earlier time because you decided to squeeze in a breakfast at the last minute. So
Yeah, well, that makes sense. There's a lot of, it's like air traffic control. There's so much going on behind the scenes
there is.
in the hospital and the operation rooms and surgical centers that we don't even realize. I'm not even privy to it as a radiologist.
Yeah, you're in a
So
different
it's
world.
kind of fun to see behind the scenes. Let's pivot a little bit. Let's talk about the mommy makeover anesthesia. So I did just have a recent tummy tuck. I was really happy with the results. The recovery was hard, a lot harder than I expected.
Yeah.
Maybe we can do a different episode on this sometime later. But for those of you listening that might be considering a tummy tuck, I think the number one, I don't know, you were with me through it, but I think the number one piece of advice that someone gave me, I'm so thankful they gave it to me, is get a recliner, because you literally sleep in a recliner for 2 weeks as you're recovering. But that's a little bit beyond the scope of today's podcast. So the question we've been getting as more and more people find out that I had a tummy tuck, people are coming out of the woodwork talking about how they're interested in a tummy tuck, but they actually want to have their breast done at the same time.
Mm-hmm.
And as a breast radiologist, have some thoughts on implants and that sort of thing, and how it affects screening, which we can also talk about in a different episode. But how much is your risk increased by being under anesthesia for a longer amount of time? So me as the tummy tuck versus someone as a tummy tuck and adds on, a breast augmentation or a breast lift. Does your risk of being under anesthesia increase the longer that you're under?
Sure. That's a great question. The risk of complication, again, a serious complication while you're under the anesthesia in that specific circumstance where you're in an outpatient plastic surgery clinic, typically those facilities will tend to really only perform surgeries with not in a hospital setting, on the healthier or healthy for the most part patients who are very low risk for a complication related to anesthesia. So that and plastic surgery itself is for the most part pretty low risk compared to other surgeries that we do. So I'd say that this would fall into the bucket of exceedingly low chance of like a serious complication occurring while you're under the anesthesia for these procedures in general. You did fine with that.
Are you out completely? Do people get tubes?
Sure. So
how does that?
Certainly for an abdominoplasty procedure is what it's called. You are under general anesthesia, either an endotracheal tube or some sort of other airway supporting device. So you're under
breathing.
general.
You're breathing for us.
Correct. Yeah.
To give
for
up
the most part,
okay.
yeah. You're not able to breathe without effectively without some assistance from the anesthesia team.
Okay. But again, for a healthy person, elective procedure, higher risk driving into that hospital than going under anesthesia, which
Correct.
makes us
And I would
better.
say that the duration of the anesthesia, as far as I think the risk that you're talking about with, really serious complications, the risk is exceedingly low for shorter procedure. And I'd say it's also exceedingly low for the longer procedures.
Okay.
Now, the longer it goes, probably there's more of a chance of you getting nauseous from the anesthesia because you're just going to require greater quantity of the anesthesia to keep you asleep for that long.
Okay.
And other risks can occur, but as far as the risk of like a serious complication like stroke, death, your risk is exceedingly small for a short procedure, and it's also very, very small for longer duration. So I would say that the difference between those two for the serious complications is negligibly small.
Okay. Really helpful. So if that is part of the reason that you're thinking about not doing both, really negligible to be thinking about.
I would say the most challenging part, like you alluded to, is the recovery period. So if you have multiple locations on your body worked on, just going to make the recovery process that much more challenging. You may require more pain medicine afterwards, which has side effects, and just more post-op pain, more difficult to get around. And I guess, a longer recovery time, but that's also outside of the scope. We take care of you just while you're in the operating room, immediately afterwards. And then so that's why, yeah, I didn't really have an appreciation for how tough it could be until I saw you, who's such a busybody and high energy,
Right.
really laid up for a couple of weeks.
Yeah. I mean, I always say you don't really appreciate your health until you're unhealthy.
Yeah, that's true.
All right. In the last few minutes here, I really do want to pivot into labor and delivery, epidurals, tons of questions about epidurals, spinal. So I had an epidural with our first son. I had a vaginal delivery with my first son. So I had the epidural. With our second and third, we had twins. I had a C-section. So I guess let's start with what are the differences? Can you, in just a short a few words, can you tell us the difference between the anesthesia between an epidural or a spinal?
Sure. So the mechanism, the kind of idea is the same, that you're giving numbing medicine to nerve roots, which supply, which carry pain from the abdominal wall, from the uterus, from the birth canal. So that's the same idea, is that you're giving numbing medicine directly to where it's needed. Now, an epidural, it's a larger needle that we use because we have to leave a catheter in place through that needle, because we're going to continuously give numbing medicine throughout the course of your labor. So we don't know how long the labor is going to last. Some people short labor, some are longer. For a cesarean section, we know those surgeries or procedures are typically, less than, I would say, 2.5, 3 hours for the most part. So we do what's called a spinal anesthetic, which again, the idea is the same. We're going to give numbing medicine into the lower back in an area through which the nerves travel to carry the pain from the surgical area. But we can use a smaller needle because we don't have to leave a catheter in place, because we can just give one dose of a long-acting numbing medicine, which will keep you numb fairly reliably for like 2.5, 3 hours.
Okay. So I think a lot of people, myself included, even as a doctor, are very scared of that large needle from epidural. What is the risk to getting some sort of spinal cord injury from that needle, or a risk to hurting the baby? Are those even risks we should be thinking about?
Sure. So any risk to the baby is, there's never been proven to be any risk to the baby.
Okay.
First and foremost. So never been proven to a risk to the baby. There's actually never been, it's never been proven that it increases your risk of going to a cesarean section. There has been some thought that it may prolong like the pushing stage of labor using certain epidural techniques, but really no, fairly minor risk to the birthing process, or no risk to the birthing process or to your baby. Now, as far as risk to, sure, people are always afraid of risk to your spinal cord, getting paralyzed, all those sorts of things. Now, while that can happen, it's very rare. It's one of our most feared complications as anesthesiologists. It is quite rare if you're using proper patient selection, for example. So not performing an epidural on patients who are on blood thinners, increasing the risk of bleeding, which can compress nerves and potentially your spinal cord. So make sure patients that have a low platelet count, for example, and can also have bleeding complications. So choosing patients that are good candidates for the epidural to minimize those sorts of risks. So the risk of those complications should be on the order of like 1 in hundreds of thousands in those type of patients.
So
very
for a patient that's healthy, no blood thinners, no platelet medications, really low risk of all these. Very low.
Yeah.
Okay.
More common risks are about 1 in 100 women get a bad headache called a spinal headache after having an epidural. There's always a risk that the epidural just isn't as effective as we hope it can be. And we have kind of troubleshooting techniques that we can use to get catheters, which aren't working great, to work. And then sometimes we have to redo the epidural, which is obviously not ideal, but it happens. And, hopefully the second epidural works better than the first.
Okay. Really helpful. I remember when I was going to get my epidural with Asher, our oldest, I was like, no, I don't feel any pain. Let's just wait. Can we wait a few minutes? I'm going to wait until I feel the pain. I want to feel a contraction. And I remember you telling me to go ahead and get the epidural even before I start feeling those. And the reason was because you said once I want it, I might not be able to get it right away. And that just has to do with the operational challenges behind anesthesia, right?
Sure. So especially if you're you're in labor in the evening and you're thinking you might want an epidural overnight, usually we run kind of a skeleton crew as far as the anesthesia staff in the hospital, and you never know what can come up. There may be an emergency surgery that comes up and you're kind of on the fence about whether you're ready to have an epidural. If you kind of put it off and kick the can down the road, when you do really need it and you're having that just, 10 out of 10 life-changing pain, then, you'd hate to wait like an hour while the anesthesiologist is dealing with some emergency. So that's one reason to get it sooner rather than later. So I would say, especially if you think you're going to get an epidural at some point, get it sooner rather than later. You're not super uncomfortable while you're getting the epidural. You're not, moving all over the bed because you're having contraction pain. It makes it kind of easier on everybody.
Okay. Well, this is really helpful. I just kind of want to summarize some of the things we learned today. So number one, the risk of having, you call it a catastrophic event, but really the risk of dying or any sort of huge event from anesthesia for a healthy person is extremely low.
Yeah.
It's a negligible amount of added risk if you're going under anesthesia for a longer amount of time, such as a tummy tuck with a breast augmentation. There are real reasons why we can't eat or drink before having anesthesia, and it has to do with our own health. We don't want to aspirate anything, so really, really important. Potential for surgical schedules to be moved around a little bit, and if that happens, your surgery could be pushed up ahead of time, so really important to make sure you try and follow the rules that the surgeons and anesthesiologists give you before your surgeries. Risk of epidurals to the baby and to yourself are very, very low for a healthy person. There are differences between the medicines that are being given for C-sections and epidural, so talk to your doctor about that. I think that's it for now. Anything else you want to add, Silas?
No, I'm just so proud of you, and I think this is great. Very light conversation, and I'm proud of you. I'm happy to be here.
I'm not sure everyone would think that anesthesiology and that topic is light, but I'm glad you do.
No, but you make it seem light and approachable, and this felt like, just
like we're hanging out in our living room?
Hanging out in our living room. So
we happen to be.
At a cocktail party, so why don't we get some cocktails and make this a party?
Yeah, you're a doctor, right?
You're a doctor, right?
Thanks, Silas.